So it's a very, as Umesh said, it's a very, very complex abnormality in the CV junction. There's a variable anatomy, complex biomechanics, a poor understanding of the natural history. And also there's so many vital structures around this. So let's need to understand a little bit of the embryology and the development in order to understand why you choose a certain specific way. So, you know, it's a Y-shaped joint where you have a central dens and body, and you have the two rings on both sides. And you also have to understand that the development, during development, which happens in uterus, that's when the pro-atlas development is so important to understand, and this is clinically relevant to some extent because you will find them in syndromic and non-syndromic in various methods. So when you have a, you know, on the 45th day when there is a head movement, that is when actually the dens tries to formulate itself. And if the dens does not form well and it forms, then you have the various abnormalities, the os odontoideum, os terminale, and various things. And that is why if you don't have good movement in some kind of muscular problems as well, you will get. So there are certain genes that express the Hawks and Pax gene intrauterine. And if you look at actually the dolphins, you know, the normal segmentation failure is because the dolphins do not move their head, so they don't have a dens. In the human, you know, in the atlas, there are, you know, these points which fuse, and if they don't fuse, you have either an anterior or an posterior spina bifida. And also the vertebral artery has so many anomalies which we are aware of, the vertebral artery itself, and also the vertebral foramen. So we can classify them based on whether this congenital malformation is in the occipital bone, or whether it is in the atlas, or it is in the joint. So you need to understand this before you try to decide whether you want to do a fixation at C1, C2, or occiput, or foramen magnum decompression, anterior or posterior. So all of these abnormalities have to be understood better. So these various malformations that happen at C1, C2 is one of the main reasons for the dislocation at the C1, at C1, C2 joint. So if you look at the definition of White and Punjabi under normal physiological loads, you know, you need to have a neurological deficit, progressive deformity, and structural pain. But here it's a little bit more complex than just saying that, okay, this is unstable. You know, you have a combination of multiple other problems like Chiari malformations, syrinx, you have acute non-chronic, and also you have the chronic degenerative atlantoaxial subluxations. Many people have tried to classify them. And these classifications are relevant for management. So, you know, Professor Goel has classified this initially into group A and B, where group A is people with, you know, instability, and those without instability in group B. So why this is important is the group A have invariably basilar invagination, and the group B can still have basilar invagination, but they have a normal atlantoaxial relationship. And that is why it's very important to understand, because your treatment, if you have a group A, is going to be an occipital cervical realignment and fixation, whereas in the group B, you can just simply do a foramen magnum decompression. But again, the various angles that, to answer Vishal's question about why these angles are important, more and more we are trying to understand the various rotations, whether it is an anterior posterior or a lateral rotation or how much of reduction, and that's why this clivus angle, clivus canal angle is very important based on this various subluxations. And that is why you have these multiple subluxations in various angles which cause the basilar invagination. And that is one of the main hypotheses why you have an instability and you develop a brainstem compression. And this clivus angle has been taken forward by Sarat Chandra from Delhi, and they find out these three angles, which are, one is the sagittal joint inclination, the coronal joint inclination, and cranial tilt. The reason for this is to do this procedure called DCER, which I think Uday is going to discuss about more in detail. So the degree of joint obliquity is a very important factor, not only in the treatment, but also in the success and failure of your procedure. If you do not choose the right patient and you just do a foramen magnum decompression in a very oblique tilt, it is going to progress and going to worsen. Again, Praveen Solanke from Chandigarh is again taking it further, saying that this can be reduced by just drilling and aligning the C2 facet. So if you are able to align it properly, then you can reduce it nicely, and all this can be done posteriorly. However, drilling this C2 is not just a simple drilling, but you need to flatten it. And if you have any vertebral abnormality, you're going to have problems. The next thing is you also have to look at the soft tissue. So one is the bony abnormality, next is the soft tissue abnormality. So you can have all these tight ligaments in the back. Along with that, you can have muscular weakness, either congenital, like in Ehlers-Danlos, in Down syndrome, with Chiari, with the Syrinx. So the whole thing becomes complicated, and that's why it's important to understand and do a thorough CT and an MRI. So this picture actually shows that the anterior contractures can be either due to muscle, can be ligament, or the capsule. So that is why you have an irreducible or a non-reducible AAD. So this whole concept of reducible in irreducible is slowly disappearing, because most people now feel that intraoperatively you can reduce most of them, either by just doing all posterior or by anterior and posterior. So I think this is slowly changing from the usual concept of reducible and irreducible. Now just to just summarize briefly which one to take, anterior or posterior, and it all depends on your reducibility of your basilar invagination. So if you are going to do posterior, you have 3 techniques which you can do, which is commonly done. One is your occipito-cervical fusion, where you are able to reduce it nicely, and you can bring normal alignment. The second one is you do an C1, C2 manipulation of the joint with or without a spacer. You don't have to put a spacer always. So this is the second technique. You can either do a transarticular or you can do a C1, C2, well-known technique. Or the third one is you can do a direct intraoperative decompression, where you can go in and you can open up, and that is where the DCR and other techniques come, where you go and actually reduce it. So these are all the techniques. And anteriorly, you need to know if you are not able to reduce, then you have to go anterior. You have to either do a direct decompression, transoral, or you can do an indirect by releasing the various ligaments and then go back posterior. So the transoral odontoidectomy, I think tomorrow you have a demonstration of that. So again, the release, anterior release, you have to make sure that intraoperatively able to release. So that's how you release. So you remove the capsule, you remove the muscles, you go into the facet joints, you go into the C1, C2 joints anteriorly, and then you make sure you can pass your instrument in, and then you're able to release the whole thing. There are more newer techniques of transoral reduction with a technique called TAPR, transoral reduction plate system. Again, this is very similarly, you can either do an odontoidectomy and then do this, or you can do it without doing an odontoidectomy. Directly you can do a reduction, all from anterior. So just to put, I might take another minute or so. So to just put this all in summary, you can either have a reducible, where you can do a fixation posteriorly. If you have irreducible, you can either go for a direct decompression or an indirect decompression. If you do any of these procedures without choosing the right patient, you can have a poor outcome. So suppose, how do you do this reduction? So the reduction, you can go in from posteriorly, preoperatively. You can reduce, take radiological pictures and see if you reduce preoperatively. If you do reduce, then you can do a fixation posteriorly. If you're not able to reduce, then you can do it under anesthesia with muscle relaxation. You can try and reduce. If it is still not reducible, then you have to go anteriorly. So that's what is the overall crux of this. And when you want to do anteriorly, you have to see whether you're going to go do an odontoidectomy, whether you can do, you have to go, if there's an assimilation, whether you want to go C0 to C1, whether you want to go to C1 to C2. So you can either do it endoscopically or you can do it open. So there are a few controversies which I'll just very briefly touch on. Controversy 1 is whether you do transoral decompression or not. Yes, there is still a role for transoral in very, very complex situations where you have to do a release, as well as if you have the dents completely aligned with the clivus. Number 2 is joint manipulation. Do you have to do a joint manipulation? Yes, joint manipulation has a very good technique. Either you drill it or you manipulate it, or you use a small cobs or a small osteotome and you reduce it, it still works well. Whether you do facetal drilling, unless you're going to do a reduction, as Sarat Chandra had explained, they do it moderate amount of drilling, whereas Solanki does a complete drilling of the bone. Whereas Goel, he just uses it to release the capsule. He doesn't do it actually to reduce it. Use of spacers, again controversial. Goel feels that everything can be reduced with a spacer, and he can also treat foramen magnum decompression, without foramen magnum decompression, Chiari malformation. So the whole CV junction he hypothesizes that can be done with a spacer and C1, C2, which has been condemned by many people, that there are selective groups of people who we can do. The last one is maneuvers, whether we can realign C1, C2 vertebra. Yes, again, Sarat Chandra feels that you can realign, and he's actually even devising a new a device which you can, even inexperienced surgeons can do to come and reduce the whole thing. Whereas Goel, he feels that just maneuvering it and realigning can actually bring this forward. Foramen magnum decompression, again, many surgeons do it. Every time you find that you cannot do a good decompression, you do a foramen magnum. It may be necessary, it may not be necessary. Even if there is a C1 assimilation, the movement in that joint is very minimal, so you don't need to do a foramen magnum decompression. So short or OC fusion. So again, a short fixation is more than sufficient even in an assimilated C1 because the movement is still preserved. You can avoid a occipital fusion. But if your anatomy is not right, if your C1 is deep down, and if you're not able to reduce, then it is better to go to the occiput. So in summary, understanding this is very complex, and trying to kind of make sense of this is not easy. It comes with experience. These are not easy and simple to manage. So it all prefers on your experience, your knowledge about how you can reduce this and how you can deal with this, and it has to be individualized. Thank you very much.